This was a team effort, this study. This study is one that we've worked on actually for quite some time. I have the privilege of just kicking us off in the first few minutes, trying to give the background behind it. And I'm going to start off this presentation then with a bit of a story. That story, it comes from actually, it was, I guess, almost a decade ago. Daniel, the two of us were at a meeting in Paris. It was this interesting event where there was scholars from the UK, and Daniel at that time was based in the UK in London. And we're meeting in Paris with scholars who were based in France at the time. And I was in Paris at that moment. And so Daniel and I were paired together on a panel. So Daniel was the presenter, I was a discussant. And at that presentation, Daniel was presenting on some of his fantastic work, focus on right to health and right to health litigation in Brazil. And it was just sort of funny that Daniel from Brazil representing Team UK, myself from Canada with not very good French representing Team France. And we had this great conversation about the right to health litigation in Brazil, learning that there's around 400,000 cases of right to health litigation every year in Brazil, but also the broad range of equity considerations that come from that. And so in Brazil, and we'll hear more about this from Daniel in a second, there is a very strong constitutional right to health. And as a result, that's led to both opportunities for citizens to demand the implementation and fulfillment of their right to health through, for example, access to certain healthcare treatments that might not be funded through the national or state level systems. But at the same time, it has created a situation where often to get access to healthcare treatments, one needs to be able to have access to a lawyer or a court system in order to exercise those rights, meaning that for those people who don't have access to the legal system or to lawyers and such, have a more difficult time making access and getting these treatments, but also providing a challenge for the government in order to properly ration various treatments that they might want to do and ensure that the most cost-effective treatments are what's provided, as opposed to those treatments that are not cost-effective, especially important when you have a limited resource, a limited budget. And so Daniel's incredible presentation was talking about, from a theoretical perspective, what happens in a world when the courts are second-guessing national decision makers' decisions about what to cover and what not to cover, and highlighting the range of equity consequences. And he put forward this idea that, or this question really, that if national and state level decision makers were able to point to a very rational process that they followed in order to inform a decision of whether to cover something or not, would the courts be more likely to defer? In other words, the title of this presentation, would the courts care when making a decision about whether the government has an obligation to cover something through, let's say, right to health litigation? Would the courts care about whether there was a health technology assessment and whether the government relied on it? The prevailing wisdom at the time was that the courts would more likely defer to the decision makers if those decisions were based on a rational, evidence-based assessment. And indeed, we've seen the proliferation of health technology assessment agencies around the world, partially, of course, to inform government decisions about what health technologies are covered, but also in some jurisdictions with the specific goal of trying to protect their decisions from judicial review, because of course it become very difficult to design a whole health insurance system about what should be covered and what should not on the basis of individual level decisions, which in the Brazil context happen 400,000 times each year. And so the good news though about 400,000 cases is that during that session, it was 10 years ago, Daniel, 400,000 cases means you can actually quantify and actually empirically measure whether the courts are more likely to defer to government decisions about what to fund and what not to fund in the presence of a health technology assessment, and actually compare to those cases where there was no health technology assessment. That kind of study, you can't do it in a Canadian context, you can't do it in most countries who are part of the OECD, because there isn't the volume of this kind of litigation in order to assess not only is there deference, but under what circumstances. So in this respect, we were able to leverage the amazing work that Daniel's been leading around the world, the team that he and Natalia brought together in Brazil to gather this unprecedented data set, which they'll be describing in a second, and test this question. I think that this is the first, well, we know that this is the first study of its kind, but it's also important because it's highlighting the role that quasi-experimental methods can bring to test these hypotheses that are extremely important, highly policy relevant, and which actually might be shaping the future of things like health technology assessment or the future of judicial review of major programs like what healthcare services get funded and what doesn't. So with that, I'll end my sort of introductory remarks, pass it over to Daniel, but just to say a final note, which is that sometimes research does take time. Daniel, took that initial spark of a presentation that you gave in Paris. It then took a beer at the John Snow pub right near where that's the famous where epidemiology got founded to further hone in on this. And it takes people like Natalia and Mathieu and others in order to actually to further brainstorm around this and bring data together, design world-leading methods and implement. So with that, Daniel, over to you, and a big thanks.
So much, Stephen, for the beautiful introduction to our research and to our joint project. That's a great start. So I think I will talk about the broader context of the topic of our research. And I think I should start with the Brazilian public health system. So in Brazil, there is a public health system, a national health system, which is the Sistema Único de Saúde, the Unified Health System, SUS. And this is a system that is inspired by the National Health Service in the UK. So it is free at the point of use, it is funded by general taxation, and it offers universal coverage. But despite all the progress that has been achieved in the last 30 years, this is a system that has some serious problems. One of them is underfunding. So the public health expenditure per capita in Brazil is just a fraction of what is spent by the UK or Canada or other high-income countries. So this is a system that has to make some very tough choices. It struggles to provide even sometimes primary care. Secondary care is certainly a problem, tertiary care. So it is a system that struggles to offer universal coverage. And in Brazil, there's also the right to health, the constitutional right to health, which has been interpreted by courts as the right to receive basically any care that can benefit a patient. So whenever there's a health need, there is a right to receive health care. So the combination of, on one hand, a health system that is severely underfunded, and on the other hand, the right, a very generous right to receive health care, this results in litigation. So there's a mismatch between what people expect to receive or what the law says, or at least what the courts say they're entitled to receive, and on the other hand, what the health system can provide. And this results in litigation. And as Stephen mentioned, here we're talking about thousands and thousands of cases every year. And the main driver of litigation in Brazil are individual claims for drugs that have not been incorporated in the National Health Services in SUS. That means drugs that do not belong to the official list of treatments that should be available for universal and regular provision. So patients, they are going to courts because they're trying to access treatments that are not included, that are not regularly and universally provided in Brazil. And that may include treatments without marketing authorization, treatments that are not registered at Anvisa, ANVISA, as you can see in the slide, is our Food and Drugs Agency. And patients' rate of success in Brazil is extremely high. We'll see the data later. It's almost certain that if you go to court and if you claim a treatment, it's almost certain that you will end up receiving this treatment, or the government will end up being obliged by a court to fund this treatment. And there are, I think, two main reasons why patients' rate of success is that high. First, because there isn't much attention to scientific evidence. So all the courts need to be convinced that a patient needs a treatment is a medical prescription. If there is a doctor saying that the patient needs the treatment, this is all courts need to hear. And on top of that, courts, they don't worry much about the cost of the treatment and the financial impact, the budget impact. The idea is that if you have a health need, you have a right to receive healthcare despite the cost, despite the distributive consequences that this may have on the health system and obviously on other health users. So thousands of cases, high rate of success. This creates incentives for even more litigation, and this results in a massive impact on budget. I'll give you a few numbers just for you to get a sense of what this impact is. In 2019, the federal government only, so Brazil is a federal state, so there is federal government, state governments, and there are municipalities. All of them have responsibilities in relation to the provision of healthcare, but different responsibilities. So for instance, at the federal level, they provide high-cost drugs. At state level, they are mainly responsible for hospital care. At municipal level, they're responsible for primary care. Okay, but all of them may be responded in claims for health treatments. So the federal government, just the federal government, in 2019 spent around $390 million US, $390 million to comply with judicial decisions. Okay, so almost $400 million just to buy drugs that were ordered by courts, the provision of which was ordered by courts. And this is more than what the federal government spent on drugs for HIV. And this is comparable to what the federal government spent on drugs for primary care. So we are not talking about something that is marginal. We're talking about something that's very, very relevant when it comes to the distribution of healthcare resources in Brazil. And this situation is probably unsustainable and is certainly unfair. It creates a two-tier health system. So there's a health system for those who have access to courts and can have access to basically anything. And there is a lower tier for the rest of the population who has a much more limited basket. And this basket is probably smaller than it could have been if resources were not diverted to benefit those on the most important initiatives was Federal Law 12401. And this legislation was enacted in 2011, and it creates a new health technology assessment system in Brazil. For those who are not, Jennifer,
Daniel,
is my
yeah, we're having a bit of trouble hearing you. Perhaps if we turn off the camera, it might help with the bandwidth. Yeah.
Bad.
Mm-hmm. Daniel, are you there?
Should I go back a bit?
Maybe
Yes,
maybe
here.
back
Can
one
you
or
hear
two
me?
sentences.
Sorry.
Yeah, we can hear you well now. Yep. Thank you.
Okay, so thank you, Jennifer. So this situation is probably unsustainable in the long term, and it is certainly unfair. It creates a two-tier public health system in Brazil. The upper tier for those who have access to treatments via courts and have access to basically anything that may benefit their health, no matter the cost, and the lower tier for the rest of the population who has a much more limited basket of services. And this basket is probably smaller than it could have been if resources were not diverted to benefit those on the upper tier. And there have been some initiatives to address this issue. And one of them, and probably the most important of them, in my opinion, was Federal Law 12401, which was enacted in 2011. and creates a new health technology assessment system in Brazil. For those who are not familiar with the concept of HTA, this is the multidisciplinary and systematic analysis of health technologies. So health technologies will be assessed using scientific information and also economic analysis. And the purpose of HTA, or one of the purposes of HTA, is to inform priority setting decisions. So Federal Law 12401 creates a new HTA body, CONITEC, which is the equivalent to NICE in England, or to the Canadian Agency for Drugs and Technologies in Health in Canada, of course. And it also creates an administrative process that aims to promote transparency, public participation, and accountability. And the idea behind this legislation was to bring more legitimacy to priority setting decisions made by the Brazilian public health system. And this legitimacy would be, not yet, the previous slide, please. And this legitimacy would come from the fact that CONITEC is an expert body dedicated for health technology assessment. So there is a more, it allows a more informed decision, and the administrative process that CONITEC has to follow in order to make its recommendations adopt many of the principles that make a process fair. The idea of procedural justice is very much part of this administrative process. So the idea is that, and now going back to litigation, that the better the administrative decision, the more informed, the more transparent, the more accountable the process is, the more deferential courts will be, right? The better the administrative process, the more deferential courts will be. Courts will hesitate to review decisions, priority setting decisions that were made by CONITEC and through this process. And if we look at the literature, there are good reasons to believe that this should be the case. If we look at the work of Colin Flood in Canada, and the work of Keith Search in England, and Norman Daniels, he makes a similar argument. And even the Pan American Health Organization, it affirmed that the reason why there is so much litigation in Brazil or in Latin America in general for healthcare, it's because these countries, they lack a transparent, systematic, and informed system to set priority. So there are good reasons, or there were good reasons to believe that this should be the case, that courts should be more differential. Next slide, please. Thank you. So this is our hypothesis. And I think after Law 12401 was enacted, I started to feel a mismatch between what the literature said and what was happening in Brazil. And this really was the driver for me to do research. Okay, so what's really going on? And our hypothesis is that the probability of a judicial decision ordering the funding of a drug reduces if the drug has been evaluated and not recommended by CONITEC. So it is less likely that the court will order the provision of a treatment if it has been assessed by CONITEC and not recommended. And in order to test this hypothesis, we look at the data in the cities of São Paulo, Porto Alegre, and Florianópolis. The lawsuits filed in these cities in both state and federal courts. In São Paulo, just state court. And these are the capital cities of 3 states that are among the 5 states with the highest volume of litigation in Brazil. So they concentrate a very important share of all the litigation for healthcare that exists in Brazil. We look at the cases that were filed between 2011 and 2015, and we had a representative sample for each city, each court, either state court or federal court, and for each year. Overall, we had in our sample 6,604 cases, and because we're looking at preliminary decisions, first instance decisions, and all the appeal levels, we had 13,263 judicial decisions to analyze. And the data, we collect the data in, so we had to do field work because the data was not available. It is public, but it's not easily available. So we had to get access to the databases of the offices that represent the government in court. And they had all the files that we needed. So that was very, very time consuming, and it took us a lot of time and work to get access to these databases. We had a fantastic team to code because we had lots of cases. So we needed a fantastic and very committed team. This team was formed basically of Natalia, I, and a bunch of law students who were then law students. And we also had a pharmacist and a medical doctor who helped us with the medical data in the court cases and in the CONITEC reports. So now I hand it over to Mathieu.
All right, thank you very much for that great introduction and contextualization. So what I'll do now is start to walk us through the data that was gathered, and then I'll go into our methods and finally present some results. So first of all, I know that the flow of cases and claims can be a little confusing, so we put together this flow chart. We start out with about 6,600 court cases, which contain actually 10,525 claims. So there may be more than one claim per case. We then excluded any claims for access to procedures, devices, nutrition, things like that, because we really wanted to focus only on drugs. We also excluded some cases where there was court-protected data, incomplete data, or outside of scope, which left us with 5,831 claims. And again, like Daniel said, there are multiple court instances, so a claim may be heard more than once, and so that leads to the final total of 13,263 judicial decisions. This is an example of the kinds of treatments that we're looking at. So not every treatment that was in a court decision was coded, but the most common treatments were standardized and coded, which was actually a huge effort because, as you can imagine, working off of court documents, not everything was standardized to begin with. So by far, the most common here was analog insulin, with about 30% of the standardized claims. And I will come back to this, but you can just take a look at this list to see the kinds of treatments that were being considered, and just take a mental note that the analog insulin was the most frequent. So again, just going over some basic data points here before we dive into the methods. First of all, for claims that were incorporated into the health system itself, into the Brazilian equivalent of Medicare, essentially, 29% are incorporated, whereas 71% were not. Whether they were registered by Anvisa, this is a marketing authorization. So 95% were, but 5% were not. And then there were more state decisions than federal decisions, with about an 80-20 split. All right, now going into some basic stats on the division between positive and negative decisions. So here we have 3 state courts. We have Sao Paulo, Rio Grande do Sul, and Santa Catarina. And you'll see that no matter which court we're looking at, we are looking at overwhelmingly positive decisions. And when I say positive from here on out, I'll just note that they are fully or partially accepted claims, which we just coded as being positive. And well over 90% of claims were successful, no matter which state we're looking at, although a higher percentage were successful in Sao Paulo and Rio Grande do Sul than in Santa Catarina. We did account for this in one method of analysis, and I will come back to that. And I think even more importantly, here we see the different levels at which cases can be heard. Going from left to right, they're more or less going in sequential order, although it's a little bit more complicated than that. From the preliminary injunction to second and third instance, to decision, first and second instance, and then to the Superior Court of Justice and Supreme Federal Court. And in the dark blue, we have the percent positive for all decisions. In the medium blue, we have the percent positive for only those cases where a CONITEC decision exists. And in lightest blue, the percent of positive decisions if CONITEC recommends SUS coverage. And you'll see at the lower courts, there's some differences happening here. In some cases, if CONITEC recommends SUS coverage, the proportion of positive decisions is higher. In other cases, it's lower. But as we progress to the higher courts, it's nearly 100% positive decisions in favor of the claimant. So it's not immediately obvious whether CONITEC is having an impact just based off this descriptive data. To figure that out, we have to go into different analytical methods. And the last thing I'll note before diving into what that looked like and what the results were is that prescriptions from patients' physicians was the sole source of evidence in 68% of judicial decisions ordering the provision of treatments not covered by the healthcare system. And it was the sole source of evidence in 45% of decisions ordering treatments without marketing approval, so that 5% sliver. So in most or nearly most cases, we're looking at basically only a prescription from the patient's physician as being the source of evidence presented. And the second note is that a CONITEC report was mentioned by litigants in 1,130 judgments, but in only 26 judicial decisions was a CONITEC report used as evidence by courts. So although the CONITEC reports were being mentioned by litigants quite often, they were almost never mentioned as evidence by the courts themselves. So hopefully that gives us an understanding of what the basic data looks like. Now I'll go into what we did to analyze the data and what the results say. And we used two primary methods. First, we did a fairly straightforward logistic regression, where we looked at the association between court type, jurisdiction, SUS coverage, and visa registration, a CONITEC report existing for the requested drug, and the outcome of the CONITEC recommendation, with the dependent variable being the odds of a positive court decision. This is actually maybe the less appropriate of the two methods for the question at hand, partially because it's not a quasi-experimental method like interrupted time series, but also because there was some missing data for some covariates, and so our sample size isn't quite as large as it is with the interrupted time series. So the interrupted time series is really the main quasi-experimental method that we used. And by that I mean it's obviously unethical to randomize litigants or claims into being granted or not, or being presented different kinds of evidence. So we have to rely on this quasi-experimental approach of an introduction of an intervention. In this case, it's a CONITEC report, and using an analytical method to determine whether that had an impact or not. And with interrupted time series, what we do is we look at time trends. We say that there is a period of time before these reports existed. There's a period of time after they existed. Can we detect a change in the slope or in the trend of the line afterwards? And if so, what is that difference, and is it significant? And the other thing I'll note is that because there were different CONITEC reports for different drugs that came out throughout the study period, we had to line up these interventions. And so we're not looking at one point in time necessarily, but we're looking at month 0, and month 0 being when the CONITEC report was issued. And then we count months before and after from that intervention point. So starting with the regression results, like I said, the sample size here is quite a lot smaller than what we're able to achieve with the interrupted time series analysis. And it gave generally inconclusive evidence on the effect of the presence and whether a decision of CONITEC report was positive or negative. It did find that state courts, that cases with medical prescriptions, that drugs authorized for marketing, and drugs not covered by the healthcare system were more likely to produce positive court decisions. So you can look into those more detailed results in the paper in the Social Science and Medicine publication, but I'm actually not going to spend too much time on this and kind of move to the interrupted time series analysis. And this is really, I would say, that the primary finding for this study, and it is that there is no significant difference that we could detect in either the trend or level. So there was no immediate rise or fall, and there was no general change in the slope up or down after the issuing of either any CONITEC report. So if we pool all the treatments together, there was no difference when evaluating only negative CONITEC decisions. So in that case, we would expect the proportion of positive decisions to drop, but we didn't see that. There was no change when evaluating positive CONITEC decisions. So in that case, we would expect the proportion of positive decisions to increase. But again, we could not detect that at a statistically significant level. And finally, we also compared positive to negative CONITEC decisions because this, in effect, allows us to to maximize the sample size and say, well, if we can't detect a difference in one or the other, there might be a difference between the two. And let me just show you what that looks like in the form of this figure, which is again in the publication. So here we have the proportion of positive decisions per month. And the intervention point, the 0 point here, where you see the dotted line going up, is the month in which the CONITEC decision was issued. And on the left-hand side, you have pre-trend. On the right-hand side, you have post-trend. The two upper lines are for positive CONITEC decisions, and the two bottom lines are for negative CONITEC decisions. And you can see that even though there's a really slight drop in positive decisions after that intervention point, really there's almost no change. And if anything, they're just continually sloping up. And this is a good visual representation of what we are saying, which is that there was essentially no difference before or after this CONITEC report. And just one note is that you can't see on this figure, but we did weight the proportion of decisions in a month to its influence on the dependent variable, and just so that the number of decisions varies, and that did matter for analysis. So that's the overall results, but it's helpful to look at one example to paint an even clearer picture. And so the example we look at is that of analog insulin, which again was the most frequently claimed drug in our sample. So CONITEC recommended against inclusion in the healthcare system because of insufficient evidence that they're more effective and safer than the universally provided human insulin. And there's been some cost estimates that providing analog insulin instead of human insulin would cost the healthcare system about 16 billion reais, or about $7 billion US over a 5-year period. So despite this negative CONITEC recommendation, there was no effect on judicial decisions for claims for analog insulin. Before the report, courts decided in favor of claimants in about 94.6% of decisions, and this is looking at 932 decisions, so a really large number of decisions. And after the report, they decided in favor of the claimant in 95.7%, or 418 judicial decisions. So in spite of this negative recommendation, if anything, we've seen an even higher level of judicial deference to this, what is in most cases just a medical prescription. And so this is the last kind of summary of all the results, which is that creating a new health technology assessment system appears to have had no impact on court decisions in Brazil, even after a recommendation against coverage. Registration and incorporation have small effects on results, but this practically disappears at the Court of Appeals level. And finally, judges are highly likely to decide in favor of the patient if a medical prescription is provided. So with that, I'll pass it back to Daniel.
Thank you very much, Mathieu. And so I want to talk about the lessons that can be drawn from our research. I'll try to turn on my camera. If it doesn't work, I'll turn it off. So I think there is all over the world an increasing recognition of health as a human right. I think this is part of having universal health coverage as a goal, as a global goal. And there's also an increasing emphasis on using HTA as a tool for setting priorities. And these two things, they may clash, like they clash in Brazil. They don't have necessarily to clash. There may be cross-fertilization, they may be mutually reinforcing, but they may clash. And I think it's important because when adopting HTA in a country, it's important to look at the players that are making allocative decisions, but that are not part of the health system, and yet they have to be taken into account, such as judges in Brazil. So it should not be taken for granted that judges will accept the recommendations and will act according to the recommendations. They may well be used to circumvent HTA. So it's important not only to have HTA, but also to convince the players that HTA is important and should be taken seriously. And I think the second conclusion is that the judiciary needs to change the interpretation of the right to health in Brazil or in other countries where they interpret the right to health as the right to any health treatment that may benefit a patient. This sort of interpretation, this interpretation of the right to health will, in the long term, probably undermine HTA. HTA will become secondary because there is an easy way to bypass HTA. And this has been happening in Brazil, and I think we can say the same about Colombia. I don't know if there's someone from Colombia here in the audience. I'd like to hear from them. But in Colombia, they have an HTA body, YETS, and YETS in practice has no big role in determining what are the duties of the health system and what are the entitlements of citizens. So this is something that's happening in other places as well. And saying that courts should consider HTA and should have an interpretation of the right to health that can accommodate HTA doesn't mean that courts cannot control what HTA bodies do and the process they follow. They can, for instance, control the legality and the reasonableness of priority setting decisions or of HTA recommendations, right? This is the bread and butter of the administrative law. But there is a difference between controlling HTA and ignoring HTA, which is more or less what Brazilian courts are doing. And finally, the literature on HTA is very much focused on Europe. And I can understand that, right? HTA is something that is very important in Europe. And I think if we can say that it started in Europe and Australia, but the literature is very focused on Europe. But it's important to look at how HTA is functioning in or not functioning in other countries, in other settings that have that may have a different legal system and where there are different players that are relevant. So I think these are the main conclusions, but I'd love to hear more from the audience about this. And I think now I'll bring it to a close. I want to thank the University of Ottawa for organizing this meeting. I want to thank Jennifer and Giles for hosting us. Thank you so much. And also want to thank all the research team involved. It's a big team and without their hard work and commitment, this research wouldn't have seen the light of the day. Thank you very much.
Thank you all so much. That was really, really interesting work. Thank you for taking the time to present it to us. So I'd invite all of the members of the audience to please type your questions into the Q&A, and I'll pass them along to the panel for their consideration. And we have one question already. And so I'll read out the question so that everybody will be aware of it in the audience. So the question is, beyond the technology being cost ineffective and sometimes not having the right market authorization, what other characteristics do the negative coverage decisions have? And in brackets, rare diseases, limited patient population, expensive oncology drugs. So inquiring about the characteristics of the negative coverage decisions. I'm not sure which one of you would like to field that question. Natalia, go ahead.
Yeah, I think I can try to answer that one. Thank you so much, and hi everyone. So basically, the large pool of cases that we have that are litigated are not about rare diseases or oncology drugs. Most of the cases are about, for instance, as Mathieu pointed out, diabetes, for instance, and other issues. But there's a difference between like the large pool of cases and the cases that cost the most to a healthcare system, and definitely cases that involve rare diseases in a limited patient population or expensive oncology drugs are cases that are extremely expensive. These drugs are extremely expensive to the healthcare system, and when they are being litigated, they become even more expensive because healthcare systems need to buy them at the market value. They often don't have the tools or the time to negotiate prices or to go through different administrative procedures to make those drugs less expensive. So pharmaceutical companies have and end up having a big power in determining price of these drugs. But when you're talking about a large pool of cases, right? Cases about, for instance, diabetes and the kinds of insulin that Mathieu was discussing. Large pool of cases also have an impact. The great number of cases are not about rare diseases or oncology drugs. They also have an impact on how healthcare systems need to respond to those cases, and that has an impact also. That has a budget impact, but that also has an organizational impact. You're going to see healthcare systems creating entire teams, deviating people and resources from one sector to another to comply with these cases, to respond to these judicial decisions. So even when we are not talking about very expensive drugs, even the large pool of cases that healthcare systems have to comply with for more common diseases, those cases are also cases that have an impact on how the policy is organized.
And any other comments from the rest of the panelists, or no? Okay, so shall we move to the next question? Is CONITEC currently able to make timely and fair decisions? Is there a part of health litigation that is more legitimate, or at least is requiring for drugs or treatments that should already be incorporated in the SUS?
I think I can take this one. And look, it's difficult to say whether CONITEC is good enough or fast enough. It's certainly much better than the previous system. But obviously, the pharmaceutical industry and patients, they want it to be faster and they want it to be more efficient. So I don't know how to evaluate and give my judgment on whether it is good enough or not. But I think when you ask about the legitimate claims, I think there's an interesting issue here, because if a treatment is approved by CONITEC and is not available for citizens, then I think you have a very strong claim that, look, this is a very legitimate legal action, right? CONITEC has assessed, has approved, and it's not there. It should be there. And there is a gray area, which are the treatments that have not been assessed by CONITEC yet. And I think there are interesting discussions about what should be done in this case. Even in the NHS, right, there is an interesting discussion of whether the health system should fund treatments that have not been assessed by NICE yet. But the main issue, and which we found the most worrisome, is that even when CONITEC has assessed the treatment and has said, no, we do not recommend, courts, they still don't care. So I would say that it would be a very interesting move from Brazilian courts if they can distinguish between treatments that were approved by CONITEC, that were not assessed, and that were not recommended. But at this moment, we don't have that. It's just, it doesn't matter what happens at CONITEC.
A question coming in, looking at the legal context in which this is taking place, is there an economic limitation on the right to health as recognized under the Brazilian constitution, as one sees in the South African constitution regarding positive rights? And if there is no sort of ability to limit the right within the Brazilian constitution, do you think that's part of why the health technology assessment is not effective in influencing judicial decisions?
I can take this one as well, Natalia.
No, we can answer that together. I think you're going to have good points on this. I think basically there is no, like in the language, on the language of the Constitution, there is no economic limitation, but you have the Supreme Court interpreting that right, and the Supreme Court could set limitations that are based on like economic availability of resources. But I think in the end, the Supreme Court has done this sometimes with a lot of exceptions and a language that opens up to a broader interpretation by state courts. So Daniel, do you want to add something to this? Yeah.
So the Constitution says that health is the right of all and a duty of the state. Federal Law 12401, the one I mentioned, it makes it very clear that the right to health should be interpreted as entitling people to have access to the treatments that belong to the official lists of treatments. So the legislation says, look, the health system has the right to determine the extension of the right to health. But courts, they don't accept that. They think that this is a limitation of the right to health. So they say, look, we have the constitutional right to health, which is above federal law. But it's interesting because there is a case now in the Supreme Court in which this is being discussed. And one of the opinions, that the judgment has not been concluded yet, and I don't know when it will be concluded, but some justice, they try to reinforce the idea that it's for the health system to determine which treatments should be provided and which treatments should not be provided. But not all justices, they're happy with that. They still believe that if a person can prove that he or she has a need, he or she has the right to receive healthcare. So in order to answer your question, no, the Constitution doesn't define a limitation, but federal legislation has defined it. And now the Supreme Court, the Brazilian Supreme Court, has to decide whether it has limitations or not.
A question that I was thinking about as well. So, so do you have any hypotheses or thoughts about why the courts are not deferring to HTA decisions besides potential lack of awareness? And I think this flows back a little bit to the first question about what are the reasons that are given for refusing or for potentially approving. And so what are your thoughts about why the courts are not deferential?
I'm going to just quickly give a broad answer and then pass it over for maybe a more specific answer, which is that a strength of this study is that it's the first quasi-experimental analysis of this research question. And so we are essentially putting numbers on something that was already widely known in Brazil, I think, which is that this CONITEC system is not having a meaningful impact. And so this maybe goes contrary to what has been written in higher income settings in UK, Canada, other similar countries. And so we don't necessarily provide an answer for why this is happening, but we at least make it, we at least put numbers to the common understanding that there has been no significant effect. However, the open question is, does this generalize to other countries, to other low and middle income countries? And Brazil is a very specific case with the empowered judiciary. So we have a concrete answer for this country, but I think it's an open question for why and for what this means for other countries.
One thing I was wondering about is the difference between common law and civilian inquisitorial systems. Does that affect the kind of evidence that's brought forward, for example?
Natalia, can I start? So yeah, I think that's a great question, and I get this question all the time. I'm never happy with the answer I give, so let me try again. So I think that there is a combination of different things here. So legal culture has certainly something to do. So in Brazil, but not only in Brazil, in Latin America, there is an intellectual movement called neo-constitutionalism, transformative constitutionalism. So in Brazil, like in other Latin American countries, there are constitutions that aim to transform society, and that includes the recognition of a long bill of rights, not only civil and political rights, but also social rights. And there is the idea that's very much accepted by the courts, that courts, they have the responsibility to make the Constitution true. So the Constitution makes so many promises. Someone has to make these promises happen, to become real. And of course, they believe that this is their role. So in Brazil, but also in other Latin American countries, courts, they are very happy to blur the distinction between law and politics, and the distinction between adjudication and policymaking. Right? There are other people from Latin America here. I'd like to hear from them. But I lived for many years in England, and I could feel the enormous difference in terms of legal culture and how courts perceive their own role within a constitution. So I think this is part of it. Courts, they don't really hesitate when it comes to making policy, or what they think is actually not making policy but protecting rights. But they're making policy. And I think the second factor we should never ignore is that what we see in Brazil is actually the rule of rescue, right? When an individual case comes, it's an individual with a name, normally with a very serious condition, with very poor health. And so it is very sad, and it's natural that we have this urge to help the person in front of us. So I think that explains a lot. And the other thing, and I think that connects to Jennifer's point, is that in Brazil, we don't have strong precedents, right? So when the judge makes a decision, so the judge says, okay, the government should pay treatment Z to Natalia, they don't see themselves as having a big impact on the public system, because they think, well, it's just Natalia. But the problem is that when you multiply these sort of decisions, and you have thousands of them, and then you start to really have an impact on policy. But they don't see it they don't see themselves as having an impact. They just see themselves as deciding one case for one individual. So I think it's probably a combination of a legal culture, the rule of rescue, and the fact that we don't have strong precedents. So there isn't much burden on the judge to say yes, but there will be a big burden on them if they say no.
I would add just one more variable, which is like it's basically institutional, how our judicial system its entirety, not only judges and courts, but public lawyers, private lawyers, state lawyers, how this judicial system has grown throughout just the last 30 years. It is definitely an institution that is much bigger than it was in the 80s. So there is like all is set for this massive litigation. You have more offer of justice services, and you have judges that have been pretty much are working in this culture that Daniel was describing. So I think it's a combination of two things.
Very, very interesting. I think we have 2 minutes, and I think I can squeeze in one more question. So I'm going to blend together a couple of them. And so a couple of questions asking, thank you for the interesting study, and asking what you think the next steps are in understanding and facing this issue. Does this project's findings pave the way for new research questions in the topic area? What next? All of that in 2 minutes.
Just very broadly, we are planning a follow-up publication looking at treatment-specific analyses, which you probably won't be surprised has a very similar message, that there's been really not much impact at all. But it's also a broader area study, this legal epidemiology, and even we're taking it a level higher, global legal epidemiology, applying epidemiologic methods to analyze legal interventions. But I'll pass it over if there's anything else to add.
Yeah, I'm also curious to know the relationship, to understand the relationship between courts and health technology assessment systems in other countries. I'm now writing a book, so I'm analyzing Brazil, England, and Colombia. So I think that there's something there. There's the relationship between HTA and right to health litigation. I think it can be very, very interesting. So this is what I'm interested in at this moment.
Yeah, and I've been looking at how, like, the other side, how health secretariats, how health administration has been reacting and looking at these and facing these issues and reorganizing themselves and hiring new personnel and creating new internal systems to comply with these decisions, but also to prevent them. So it's kind of anticipating what is going to be litigated and then trying to incorporate these new technologies, sometimes at the state level, sometimes in a sided list of new technology that is only going to be provided administratively in one particular state. So there is like a broad range of topics that can be explored there.
This is great. And can I would love to permit myself to ask a question about methods as well and next steps, because as I was listening to you, I was thinking how interesting it would be to adopt a qualitative method to look at the actual reasons given in class of decisions for different kinds of drugs. Could be really interesting to try to delve a little bit more into the explanation for the reasons for the pattern you're seeing. But with that, we're at 1 o'clock. And so from me, a hearty thank you for presenting your work. Great pleasure to partner with GSL and with all of you in Brazil doing this excellent work. Thank you to our audience and for the really useful questions. So with that, I will wish you all an excellent rest of the day and look forward to seeing you at some of our future presentations.